Welcome back, everybody, to the Aches, Pains, and Gains podcast. I'm one of your co-hosts, Thomas. Over there, I got my other co-host.
Yo, my name is Danny, and I'm also a host.
And today, we got a very special episode joined by not one, but two guests. To my left, I have Kelsey Goodmanson. Kelsey, say hi to everyone if you'd like.
Hello, everybody.
And Kelsey is one of Danny's athletes and also the Bridge City Barbell social media manager. I believe that is the name
like that term.
of your position. Okay, perfect.
Definitely.
And then to my right, we have Christine Epp. Did I get that correct?
Absolutely.
Perfect. And Christine here is a pelvic floor physiotherapist who will be walking us through the very often misunderstood topics of the pelvic floor, pregnancy, and kind of how that all relates to physical activity. I guess maybe to start, Kelsey, do you want to tell everyone who you are and what you do?
Yeah, for sure. So I'm in my professional life, I'm a personal trainer. Have been for, I guess, just over a year now. And I've been one of Danny's athletes with Bridge City Barbell for, since July, I guess. July was my first meet.
Right.
So powerlifting, personal training, and basically living in the gym.
Perfect. Living in the gym.
Sounds like a lot like
it.
us.
Yep.
Yeah. And Christine, who are you and what do you do?
Well, I'm mother of three amazing boys. They are now young adults, and they have brought three wonderful partners to our family. And so my husband and I have a wonderful opportunity to hang out with those young adults and enjoy that. In my professional life, I'm a rather experienced physiotherapist. I've been working as a physio for 32 years, and I've been doing pelvic health work for 22 of those 32 years. And so currently I own and operate Women's Wellness Physiotherapy, which is just a solo private practice. I work with a group of obstetrician gynecologists. And hang out in the pelvis. It's kind of a strange place to hang out, but that's where I live, trying to help women and others improve their pelvic health and coordinate and integrate it with their life and movement and feeling better and reducing symptoms.
Right on. We were talking just before we came down. You've been practicing for about 32 years, right? And she actually graduated with Blaine Mackey.
No way.
Yeah, so we're all very familiar
That's cool.
with the Mackey,
Yeah.
the Mackey crowd and whatnot. So it's kind of interesting that you guys were classmates.
We were
actually.
classmates, and then we worked together as well for quite some time.
Wow.
Right.
He was my neighbor.
Wow.
Yeah, in one of the private practices that we worked at. So
Wow.
And back then, physio was a bachelor's degree, correct?
correct.
Oh, wow.
Yes.
Okay, yeah. Wow.
Small world.
Yeah, it is
That's
definitely
crazy.
a small world,
It is
especially
a small world.
Oh, in
especially here.
Saskatchewan. But
Yeah,
I mean,
Saskatchewan and Saskatoon.
Everyone knows everybody, but
It's tiny.
yeah.
Yeah, behave yourself because you'll meet them again.
Yes, yes,
for
no,
sure.
exactly. Okay, let's kick it off today with some aches, pains, and gains. Danny, you want to lead it off here? Kind of tell us about your
Okay,
aches,
cool.
pains, and or gains.
I'll start us off. So what are we, like 13 days out from Westerns right now?
13, yeah.
13 days out, and in typical fashion, my upper back soreness always comes back, 3 or 2 weeks out. And like right now, it's like screaming at me. So I booked 2 massages, one for today and then one like later in the week. Hopefully that'll, I don't know, ease things up. But other than that, gains are flowing. We're hitting some big weight. We have one more week to push. And that's...
I guess for Christine, when are we all competing? That's 2 weeks from now, right?
Well,
Ish, right?
2 weeks from yesterday.
yeah. March 7th to the 10th. That's what it is.
Yeah. So
So-
we have the Western Canadian Championships in
Yeah,
Moose Jaw.
I should have explained that. My bad.
Yeah, no, it's okay.
yeah.
Yeah,
Excellent. Well, good
Yeah.
luck with that.
thank
yeah,
you.
Very exciting. There's 21 of our athletes going, so it'll be a busy weekend, but a really exciting weekend.
Mm-hmm. Absolutely.
Yeah.
Hey, Kelsey, do you want to go next? Tell us about your aches, pains, and or gains.
Yeah, I think the gains are definitely there. I've been hitting some good numbers and hitting some PRs for sure.
Crazy.
Yeah, things are going well. Definitely some pains as well. Nothing major, just kind of general fatigue, I think, more than anything else. And yeah, back's getting a little bit, maybe not the same extent as yours, but yeah, I've been dealing with a little bit of upper back pain actually since provincials. That's kind of been creeping its way back up, but No, things are good. I'm managing well, and yeah, just try to focus on recovery and see what else we can push.
Quick question before we go forward. Do you think going to beltless has made a difference for deadlifts?
Honestly, I haven't noticed
Really?
any differences. The only differences have been positive, which is something I have questions for you about regarding pelvic floor issues. But no, overall, I'm really happy with how things are going. And
So you
just
removed
excited.
your belt for deadlifts,
Yeah.
versus wearing it.
Yeah.
Okay, yeah,
Yeah.
interesting.
Yeah, I showed up to the gym one day and she's like pulling like 90% plus. And I was like, in my head, I was like, where's your belt?
The hell?
And then she smoked it. And I was like,
Yeah.
what?
Kelsey's a very strong deadlifter. She pulled over 400 pounds yesterday.
Yeah, 408.
Wow.
Yeah.
Impressive.
Yeah.
So okay, that's a really good segue, but we're not going to segue quite yet because Christine, do you have any aches, pains, or gains that you'd like to report?
Good news. I don't have any aches or pains to report. Gains for me right now, a few complex things going on in my world, supporting my mom through life transition. So my gains have been in being able to also prioritize myself and movement and exercise, getting to the gym consistently. So pretty happy with that and being able to do that in spite of a lot of other things that could actually get in one's way and stop the forward progression of staying strong and being fit.
Awesome.
Perfect.
I mean, the transitioning your mom to long-term care, that can definitely be a difficult transition, and navigating that and still trying to find time in your life. But I'm glad to hear that you're still managing to find a way to keep active and keep moving.
Yeah.
Unfortunately, she was 8 weeks in the hospital, so finding time to work and be there every day to support her and advocate for her, which is unfortunately required in this current environment. And then also, do what I need to keep myself moving forward. It's challenging, but happy to report it worked well.
Yeah, our healthcare system's in rough shape.
A little bit, yeah.
I was telling Christine upstairs that I just finished like 6 weeks at RUH in the trauma ward and whatnot, and yeah, it's definitely eye opening seeing the system that is only partially working and is overtaxed and whatnot. But that's not the topic of today's episode.
That's right.
I'll just run over my aches and pains and gains here real quick. Honestly, for once, I don't have many aches or pains to report, which is rare for me.
That's wild.
Somehow.
Usually a Band-Aid.
I'm usually a Band-Aid. Usually I have some sort of kind of knee pain, typically like patellofemoral pain, or I've had kind of on and off chronic low back pain for quite some time now. And it's been quite the journey figuring out how to deal with it and cope with it. But, sometimes pain has flare-ups, and I found, I think, ways to manage it. And then the competition's closing in quickly, and I think the added pressure, actually, I find it beneficial. I think it actually can increase some of the aches, pains, and gains, I guess. But yeah, this time around, I'm actually feeling really good. So
Because you thrive under pressure.
I mean, I guess so. Maybe sometimes.
Yeah.
But with that said, I would love to dive into our episode here and the topic. So, Christine, earlier you mentioned you're a pelvic floor physiotherapist, and I'm sure some of the listeners here are not entirely sure what the pelvic floor is. So, could you maybe describe what a pelvic floor PT is versus maybe just the standard PT? Not that there's anything wrong with that, but just someone that doesn't have the qualification, and maybe get into a little bit about what the pelvic floor is as well.
Sure. It's a big topic, so I hope I use language that's helpful. I think at the end, you'll have my contact information, and I'm very happy to have questions. So if I'm not communicating in a way that's effective, I know I use lingo. I think we all do when we have our area of interest and expertise. So I'll try and keep it clear, but please feel free to shoot me questions if you have any. So a pelvic floor physiotherapist, or sometimes we're now trying to think of it more as a pelvic health physiotherapist. It's a little bit broader term. I don't just treat the pelvic floor. I treat anything that exists in and around the pelvis, which is everything from the mid-back and the diaphragm down past the hips and into the knees. So it's really the whole region of the pelvis that we have done additional training in. So we have standard physiotherapy background. I'm an orthopedically trained physiotherapist and practiced in standard orthopedic or musculoskeletal physiotherapy for many years, and then added additional training to be able to internally assess the pelvic floor muscles, which exist inside the pelvis. So you have to have extra training to know how to do that. It's not something that we learn in undergrad. And so you take extra training, you get certification, and then you continue on a journey of lifelong learning. What I learned 20 years ago about the pelvic floor, I really don't necessarily use that much of it anymore because the field has evolved so much in the past 20 years. So it's a very exciting thing to be doing. The pelvic floor muscles are the muscles that are at the base of the pelvis. They support the pelvic organs. They assist with continence, so keeping urine in the bladder when it should be in the bladder, gas and stool in the rectum when it should be in the rectum. As I said, support the pelvic organs. They're also the muscles or the dynamic muscle system that creates stability for the pelvis, the sacroiliac joints, the pubic symphysis joint, and they are the base of the entire core system. So the core doesn't function without the pelvic floor, but forever we have talked about core muscles as primarily the abdominal muscles. I think branching out a little bit more now to understand that the core is the center, so it's also the back, it's also the diaphragm, but the base of it, the literal foundation, is the pelvic floor, and it's been ignored for really mostly forever, outside of kegels, which I think we're going to talk about later. And it's so much more than that. Everyone has a pelvic floor. Every human has a pelvic floor. And everyone can experience pelvic floor symptoms, pelvic floor dysfunction, pelvic floor problems. So pretty important stuff.
Yeah, sounds super important. And you kind of gave us a very good tee up there for pelvic floor dysfunction. Could you define it for us and maybe describe what that looks like in the clients you treat?
So pelvic floor dysfunction is a very broad conversation. It really refers to anything that might be related to problems with the pelvic floor muscles. Pelvic floor muscles can have a wide variety of problems, and there are many symptoms that can be experienced as a part or as a result of pelvic floor dysfunction. So I may forget things and come back to them later, but the primary symptoms that are associated with pelvic floor dysfunction would be urinary incontinence. So leaking urine, having urine drip or dribble when you cough, laugh, sneeze, run, jump, lift, bend, squat, etc. That would be called stress urinary incontinence. And then there's urge and urge incontinence, which is having a strong urge and leaking urine at that time, or not being able to control an urge when you're trying to get to the bathroom in time. Bladder dysfunction, so pain with filling your bladder, pain with storing urine, pain with emptying, an inability to empty urine effectively from your bladder, so difficulty starting, difficulty finishing, feeling like you never truly empty. Those are all bladder-related pelvic floor symptoms. Bowel symptoms, we can have difficulty with control of gas and control of stool. We can also have difficulty with emptying or with evacuation. So there's constipation, which is one thing that's more through the gut kind of a problem with our gastrointestinal system. But then oftentimes we can have difficulty with actually getting stool or gas out. So we can have trouble keeping it in, trouble getting it out, pain with any of those things. And a lot of that relates to pelvic floor dysfunction. We also will see for women or assigned females at birth that we can have difficulty with pain with our menstrual cycle, pain with intercourse. Also exists for gentlemen, obviously not the menstrual cycle part, but pain with intercourse. So there are different reasons for these kinds of things, but those are really common things. We know that affects around 25% of women who will have pelvic floor dysfunction over the course of a lifetime, which is pretty significant. And that really depends on the study and how we're defining things. Incontinence, we'll see people assigned females at birth 51.1%. It's kind of a specific number. 13.9% of assigned males at birth. Since we're talking about athletes here today, we've got a 2021 study that showed across 38 different sports. For females, 45%, and for males, almost 15% leaking urine with movement and exercise and activity. So it's not just a pregnancy and postpartum problem. It's significant for elite athletes. So people who do anything at a high level and are pushing their bodies will commonly experience pelvic floor dysfunction. There's one more stat I just wanted to find here. It's in the realm of 95+% of people who experience low back pain have been shown to have some form of pelvic floor dysfunction. So low back pain, pelvic girdle pain, SI joint pain, pubic symphysis pain, and the hip attaches to the pelvis as well. So hip pain. These are all commonly related to pelvic floor dysfunction. The piriformis muscle, we get a lot of people with piriformis syndrome. Piriformis syndrome is a problem because we try and treat it from the outside, but the muscle actually attaches to the inside of the pelvis and is strongly associated with the internal aspect of the pelvic floor muscles. So some of these common, frustrating musculoskeletal or orthopedic concerns are also commonly related to pelvic floor dysfunction.
Wow. So just about half of elite female athletes deal with pelvic floor dysfunction.
Wow.
Which seems like a really broad topic that encompasses a lot. We were talking just before we started recording as well, kind of the birth of this idea for this episode, as I pitched it to Danny and I said, hey, do you know what to do if your athlete is, dealing with incontinence at all? And Danny was like, no. And then I also mentioned, is it safe for those expecting childbirth to continue lifting? And he was also like, I don't know. And we coach a lot of athletes that are female, that have had kids, are planning to have kids, or are struggling with incontinence or all kinds of aches and pains related to the pelvic girdle in general, like especially like low back pain or SI pain. And we were talking that in all our exercise science degrees and personal training certifications and strength conditioning certifications, it's hardly even mentioned. So yeah, it seems kind of ridiculous that it's not mentioned at all.
Well, I saw it just started like a couple of years ago, like all over social media. You would see like posts of like women deadlifting, and then they would urinate a little bit. And at first I was like, that's kind of weird. But then it started happening to a couple of my athletes, and I was like, and then I'm like, oh, okay. So then a simple Google search, I'm like, is this okay? And all I basically said was, yeah, it's fine. And then like other like I don't want to call them like influencers or whatever, but they started like making like information posts about it and that, and everything said it was fine. Yeah, you're not in danger of like, I don't know, injuring yourself or anything further. So I'm like, I guess it's normal.
Right. I'm going to jump in.
Yeah, absolutely.
So we've kind of normalized this, particularly because we don't really understand it. So it's distressing. It's bothersome. No one wants to leak urine at any time.
Exactly.
No one wants to be on a lift platform and leak urine. You don't want to do that in the gym. You don't want to do that in competition. That's not cool. So it's common, but not normal.
Yeah.
Super important language in the pelvis, common but not normal, because we don't know. We don't talk about these things. And I can't believe I didn't bring it up, but in terms of pelvic floor dysfunction, pelvic organ prolapse is also one of the common challenges for people who lift heavy things, whether that be at work or recreationally for fitness and competition. And pelvic organ prolapse, like stress urinary incontinence, the leaking with lifting something heavy, it's a problem of pressure balance. So we don't have good balance within the core muscle system from the diaphragm down to the pelvic floor. We're not balancing those pressures effectively. And so we can have urine pushed out when we activate the external muscles very strongly. So it can happen. It is common, but it is, not normal. And that same pressure can cause descent of the pelvic organs. Again, common. To a degree, there are some parts of that are normal. We want to be careful to not turn it into a pathology if it isn't a pathology. But what we want to do is understand it, and we want to manage it, and we want to balance those pressures so that we feel strong and confident doing all of the things that we want to do without having any experiences of symptoms or distress or bother or being told, okay, yeah, that's not good. You can't lift that because it's not true. But how do we lift it, and how do we balance the pressures so that we don't have symptoms, we don't leak urine, we don't feel downward pressure on our pelvic organs? These are the key things.
Wow. Okay. You learning a lot right now, Danny?
Dude, I'm so ignorant when it comes to this topic.
Yeah.
I'm taking a lot in.
Yeah, but you're interested and you're willing to have a conversation.
Absolutely.
And you're willing to sit in the presence of things that are not necessarily super comfortable. And that's all you have to do.
Yeah.
That's good
Yeah.
point. Kelsey, did you have anything you wanted to jump in there with? I remember we talked at the gym about a question you had. This might be a good spot to throw it in there.
Yeah, so I guess just speaking from my own experience, I'd never really had issues with it until I, say, worked up to a certain weight. When I was training with a belt anyways, provincials actually was the first time that I was like, holy shit, this is, like, I actually did basically completely, whether it was urine or whatever, but because I would always, run to the bathroom even in between deadlift attempts. And my second attempt, full on. And I was just, I didn't really care at the time because I was, you got to do what you got to do.
Mm-hmm.
But kind of like Danny said, I always seen on social media, oh, it's normal. It's normal. So I was like, okay, whatever. This is just something that will happen. I'll suck it up and I'll deal with it. After provincials, which was just this past October, even throughout training, I've almost found it getting worse and worse and worse to the point where I couldn't fully comfortably deadlift because I was so in my head about it, which is actually what spurred on the whole beltless deadlifting thing. Since not using a belt, I have zero issues with it. Whereas before I was like, am I bracing incorrectly? Is my core weak? Like, what is going on here? So I guess maybe a couple of questions there. Is something like that, the incontinence part, is that load dependent? And as it relates to belted training, is that okay to go beltless and not have any issues with it? Like, am I risking, some other injury there? Or I guess what's your take on that?
First thing I can do is reassure you that you're in this group of women who lift heavy things who experience this. And so again, it is common, but not normal. We don't want to just accept it. We want to understand it, and we want to deal with it and manage it. So you don't have to put up with this.
Yeah, because it doesn't feel good.
No.
Like, regardless of whether people tell you it's normal or not, the last thing you want to do is be deadlifting and holy shit, I'm pissing on the platform in front of 100 people. It's not comfortable.
It's not, and it's not normal.
Yeah.
But it is common, and so you're not doing anything wrong. You've not made poor choices. This exists because the balance of pressures is not ideal. We should not have to run to the bathroom in between lifts in order to be safe.
And that was very much forced. Like, I was doing it out of
survival.
Yeah, exactly.
It's a protective mechanism. So it's absolutely a logical protective mechanism. It's just not our ideal protective mechanism. So your brain, part of why it was getting worse, I would suspect, obviously we haven't assessed anything, so I can't tell you for sure, but when we experience distressing, bothersome symptoms, our brain is going to take action to protect us. The protective mechanism in the pelvis is to actually increase the tension, the fight or flight, with the pelvic floor muscles. And so your muscles become less resilient. They become less adaptable. They can't shift or adapt to the pressure that you're generating. If you have a belt on, you have more pressure coming from above. Mm-hmm. Your pelvic floor is becoming more and more tense. So when you load it, it doesn't have that give that we need. We don't want a tense, rigid pelvic floor. We want a flexible, dynamic, able to come in, if you think about a balloon, if we're going to add pressure to the balloon from above, we need to be able to do something dynamic at the bottom. And so we don't need a tense, rigid pelvic floor. But as we become more and more distressed, our subconscious brain upregulates our protective mechanisms, which are muscle tension. And we end up with a rigid, tense pelvic floor, which can't adapt. And then we leak more.
Yeah. And that's what I found is normally I would just think about, my normal kind of deadlift setup and going about the lift. And then over time, I was thinking more about almost be like hypertensing, and that seemed to make things so much worse.
Right.
At lower and lower weights.
And you were tensing the external abdominal musculature, which increases the intra-abdominal pressure, which puts more pressure into your pelvis and causes an increase in problems. So you modified those pressures effectively, and you were more confident. And so now your pelvic floor can start to be more dynamic and adaptable again and work on balancing pressures more effectively. Mm. The other thing that I can say is that it is exceptionally common. Almost every day, I meet women who say, well, I have a weak core, or it must be because my core is weak. We've told people this for so long that we've started to believe it. And it's actually false. There is zero chance that your core is weak if you can deadlift over 400 pounds.
Okay.
There's no chance you have a weak core. You might have a core that isn't functioning as well as you might like it to function, but it's not because of weakness. Hmm. So what we need is we need to take the core muscles and we need to coordinate them and organize them, including the pelvic floor, because the pelvic floor is the base or the foundation of the core, so that we can really get that whole system firing super effectively. We might get to this later, but the other thing I can tell you is that it's really important in between lifts that you lengthen and relax your pelvic floor and your core muscles. And we rarely in fitness and with training talk about lengthening and relaxing core muscles. Mm-hmm. We only ever talk about activating and holding them on and keeping them tight. And women should have a tight core, and you want to have your abdomen flat. And there are many, many reasons why, but we walk around with these muscles in tension. So there's already pressure on your bladder, and then we load it, and it just doesn't always end well.
Yeah.
Yeah. So
interesting.
Putting a belt on is a strategy to reinforce the core muscle system so that you can increase the other weight. If you're training gradually, which everybody does, your core, if we're working on it effectively, really should be able to do much of the work by itself. And we might want to add that strategy of reinforcement, but we don't want to add that strategy of reinforcement if we don't have a pretty darn confident base.
Right.
So we need that bottom to be really also trained up with the rest of you so that it can manage the pressures that you're generating both actively, and then if we add passive pressure from a belt, that it can tolerate and sustain and work effectively for you. So the right idea with lifting super heavy things is to make sure that you have the balance of pressures that you need to be able to do that task successfully.
Wow. Could not have teed that up better.
Yeah.
Danny, do you have anything to add there? Kelsey's your athlete. I know you're making quite a few faces there. I feel like
it's just how you're explaining it makes perfect sense, and that difference in pressure. How if you're you got a higher pressure up top, makes things worse down below. So
path of least resistance.
Yeah, exactly. So
absolutely,
it's making sense.
Good.
I was like mind blown, but it's good.
Yeah. And the pelvic floor works together. It co-contracts when you tighten your pelvic floor. This is every human. When you tighten your pelvic floor muscles, you get transversus abdominis contracting, and you get multifidus in the spine contracting. So that's your stability system. These are the support muscles. And so if we initiate support from the bottom up rather than activating the core by bringing your belly button to your spine, which is an intra-abdominal downward pressure, we actually are going to see that setup of the inner core muscles as we're starting to talk about them. The pelvic floor is a part of the inner core. And as that inner core activates, then we create that base or foundation, which is not just the pelvic floor, it's that whole lumbopelvic, lower back, pelvic floor system that gives us that sense of support and stability, and then we can do lots of heavy things. When I've had opportunity to work with women who lift really heavy things and do super dynamic, crazy physical activity and have had leakage, when we sort out who should do what from a muscle perspective, which muscles are the prep team and which muscles, I call them the get her done girls. All the other folks, the movement muscles, the ones that are going to do the heavy work. If everybody's got their right job and the group project is well organized, that we start with the prep team and then we add the movement and then we give everybody a break when the outcome has been good, we're going to see a lot of positive change. And what these women have reported to me pretty consistently is, in fact, once we give the right responsibilities to the right muscles, they're actually lifting heavier quite quickly because we're not trying to use the muscles that need to be doing the heavy work for stability or preparation. Right. So we actually can free them up to do more dynamic work, which lets you lift heavier things and be more forceful with the movements that you want to be doing, which is kind of exciting.
Absolutely. Yeah. Especially if the goal, in powerlifting is to lift as heavy as possible. I think it's an easy sell for lifters like us to be like, if we can get this sorted, you can likely lift more because it's such an important part of the core complex.
Let me tell you a little story. I like to think about this whole system like going to a concert at SaskTel Center.
Sure.
So we're going to go to a concert. The stage and lighting crew need to get there first. Mm-hmm. They need to get things set up. They're going to be around during the event, making sure it's going well. After the audience and the performers leave, they're going to pack it up, put it away, take it off to Edmonton, let's do it again. Mm-hmm. They're paid by the hour. They do not work harder than they have to, but they're really effective. If they don't do their job well, that's when we notice them. The lights don't come on. There's a hole in the stage. Beyonce's falling through. Somebody is going to be in trouble here, right? So if we think of the pelvic floor and the rest of the inner core as that setup crew, they're submaximal muscles. They don't work in a maximal situation super well. They're subtle. They're usually automatic. But when we start to see issues, then the brain is like, whoa, what's going on? Like whoever's in charge of this whole program is going to be finding these folks and giving them heck, and they're going to be all stressed, right? Yeah. So when we have the whole process working really smoothly, we just have great events and everybody loves it, and we carry on doing the same thing. When problems arise, now everybody gets all out of sorts and the whole thing doesn't go super well.
Wow. That was such a perfect analogy.
That was perfect.
That was so
That was good.
I did want to ask too, and based on the stats you kind of shared earlier, why is it that pelvic floor dysfunction seems to predominantly affect females?
Well, women go through different life experiences than men in terms of their pelvic health, and we have different structural anatomy. So the anatomy is a little bit different, and we do have different variables. Obviously, pregnancy, which we're going to talk about at some point, is one of those variables. But I meet a lot of women who have never had babies. They have never been pregnant, and yet they also have pelvic floor dysfunction. I actually believe that some of the male pelvic floor dysfunction is very underreported. So we've been focusing more on women's health in the last 5 to 10 years, which is great. And so I think we're talking more about it. I don't think there's a lot of conversation yet about male pelvic floor dysfunction, and yet it is very, very common. I think the numbers are probably underrepresentative. From a leakage perspective, because of the length of the male urethra, there's an inherent anatomical advantage to avoid leaking urine. And pelvic organ prolapse is not going to happen because pelvic organ prolapse is descent of the pelvic organs and the vaginal walls into the vaginal space. And so again, the anatomy is different. So pelvic organ prolapse is not a male issue. Men can experience anorectal prolapse, which is a common thing actually, but pelvic organ prolapse lives in the world of assigned females at birth.
Okay. I would have to agree too on the idea of it being underrepresented or underreported in males. I actually have a friend who was once upon a time squatting heavy, and he was a track athlete at the time, and he was telling me that he was squatting down and he kind of held in some gas at one point during the movement, and he felt something like almost like straight strain in that region, and it hurt like a fair amount. So things weren't moving right after that, weren't feeling really good. So he went to the physiotherapist for the team, and after talking for a little bit, the physio was eventually came to the conclusion where she said, I think you actually strained your pelvic floor. And so it's something that can affect males. In terms of leakage, I've only ever seen it happen once to a male on the platform at meets that we've been
Yep.
at, and that kind of makes sense with the anatomical difference that you were just explaining.
It can happen. The most common time when we'll actually, currently discuss male urinary incontinence is after prostate surgery because the mechanism is changed. So post-prostatectomy, pelvic floor dysfunction, pelvic floor physiotherapy for people who have to go through prostatectomy is very common. In Saskatchewan, we have a prostate pathway, and there's pelvic floor physiotherapy as a part of that. But there are also things like chronic prostatitis, which are not actually infection or inflammation, and they're actually commonly associated with pelvic floor dysfunction for men. So there are more things out there, I think, than we do talk about. And control of gas and stool would probably be in that category for people who have a lot of pressure in their abdomen.
I kind of a personal story on my end, but recently I had a really, really bad kind of stomach bug, and I kind of had fluids coming out of both ends. We've all been there. It was a miserable process, miserable 24 hours essentially. And I remember feeling fairly constipated for about a week after that. I was telling you guys this at the gym, but I really felt like I could not squat heavy and I could not squat deep. Like we have a depth requirement in powerlifting where your hip crease needs to go below the top of your knee. For some people, that's like quite far down, but I was so worried about squatting with this intra-abdominal pressure on top of the constipation I was experiencing. So, I mean, I guess looking back upon it, I was experiencing some sort of pelvic floor issue, right?
Correct. Absolutely. So anybody that's experiencing diarrhea or loose stool or excess gas, so people who go through Crohn's and colitis disease management, very common that those people would experience pelvic floor dysfunction. But even the 24-hour diarrhea will affect your ability to confidently relax and know that you'll be fine.
Yeah.
And so if you can't relax a muscle, you can't tighten it again.
Right.
I spend the majority of my day, this is a surprise to a lot of people, but I spend the majority of my day helping people figure out how to lengthen and relax their pelvic floor so that they can then tighten and engage it sufficiently to do whatever it is they want to do. Because the muscles become hypertonic, overactive, protective, both in terms of our prior conversation, Kelsey, and what you were just describing. So those are not weak pelvic floor muscles. It didn't become weak in 24 hours.
Right, yeah.
It was already busy and so could not do for you what it normally does for you. And you noted the functional change of that.
Wow.
Interesting.
Very, very interesting.
It's a thing.
Yeah, no, it's
a
definitely a thing.
And many, many people will have experienced this and just, I'm not recovered yet. Well, it's not because of the GI bug.
Yes, yeah.
It's because of the consequence of the GI bug and the things that we do in order to manage those challenging circumstances.
Yeah, and with my bug too, I remember like my diaphragm being like sore and exhausted. I had trouble taking deep breaths in from the enormous amount of pressure and whatnot that was placed upon my core, right?
Right. And I'll jump in on that to remind us that we talked about at the beginning that the diaphragm is at the top of this core system and the pelvic floor is at the bottom. And so how we breathe and what we do is extremely, extremely important. We also have some research to show that people who have difficulty with jaw and temporomandibular joint TMJ issues and problems with elevated tension, that's correlated with elevated pelvic floor muscle dysfunction as well.
Wow.
So there are a lot of ways that people, I have this jaw thing. Well, if you talk to somebody who has a jaw thing and they didn't just, have an injury to their jaw, it's probably a tension-based problem. And we kind of know that in the jaw, but they're probably also, or could be, would be worth, if you're comfortable, having a conversation about pelvic floor things.
Right.
Not everyone needs to talk about this. I understand that, but, for those who want to.
Fair enough. I did want to ask as well, kind of segueing into the next topic. We'll probably revisit this as well once we talk about pregnancy. But what can guys and gals like us three here do when clients are reporting these types of symptoms? Because obviously these types of conversations have come up with us in the past, and I've had clients report incontinence, or even I've had a client report feelings of prolapse and whatnot. Thankfully, at the time, I did know that pelvic floor physios existed, and I kind of referred her there. But I guess it also ties in with when to refer to someone like a pelvic floor physio, and when is it something that maybe we can help them modify?
So, I mean, I'm super excited to be here talking today because I think you guys are going to lead the way in terms of the system change and being able to start to normalize some of the conversations that need to happen, and that's really exciting. So, I think just knowing that this is coming and being willing to listen and be present for those conversations is the first thing. I think we want to validate people's experiences and say, yeah, that's a common problem, but it's not normal. And we want to make sure that we're taking care of this because we can do better. That's pretty important. We want to reduce fear and we want to get people to be able to understand that this isn't something they're doing wrong. This isn't a bad choice or a bad decision. This lives in the pelvis, and it's something that is generally poorly understood. But yeah, you can have that conversation, and then you can decide, okay, can we change the pressure of that movement or in that situation? Can we understand how you're activating your muscles so that we can look at ways to do this differently that might be more successful in terms of balanced pressure? So you don't necessarily need a physiotherapist right off the hop. You need to look at the movement and say, okay, what's your strategy? How are you doing this? There are no safe exercises and there are no bad exercises. There are exercises that we want to do well with balanced pressure. And so bearing down, holding our breath, strain, different ways of talking about it or looking at it. Maybe it's just a simple correction or modification. Kelsey took off her belt and that probably changed the pressure, but it also maybe gave you space to think about the movement from a different perspective. We don't really know when we change things why it's working, but trying something different. If we're not having good outcomes with what we're doing, let's do something different and see if it works better.
Mm-hmm.
Mm-hmm.
Is it more effective? Does it still allow you to accomplish your lifting goals and not have that pressure imbalance? Those are things that can be looked at. Pelvic floor physios, I think we need to do a better job of collaborating with fitness professionals. I think there's a huge opportunity now to be able to put it together and work collaboratively. So if somebody comes to see me and they're wanting to be lifting, then I can assess and I can have a conversation with the individual, but also potentially with the fitness professional to be able to say, okay, these are some of the things we're seeing in clinic. Can we do this? In certain circumstances, the physio and the coach and the athlete will be together present in the environment and can set up a situation where we're actually all problem solving together to look at, taking my knowledge or our knowledge and combining that with your knowledge and then facilitating the best possible outcome for the athlete. So I think that there's a lot of opportunity to work together on this and to change the language, to reduce the fear and to just improve the overall atmosphere for athletic performance.
Right, right. So that's awesome. That was really well put. Danny, you have anything to add on
I just
that?
like how she stated that there are not bad exercises. You just gotta.
Yeah, we're big.
I'm
Movement
big in that.
optimists.
Love that.
Yeah, here.
It's good to hear.
100%. And movement is the only way we're going to promote health and longevity and create our health span equal to our lifespan. It's the only way of the future.
Yeah.
And we need to facilitate confidence with movement, and we need to know what that person's goals are and help them to achieve those goals, and then figure out what we need to do to give them the knowledge and the skills and the tools to be able to do just exactly what they want to do to the very best of their possible abilities. So yeah, I'm very much on the side of this isn't something that we need, you shouldn't be doing that. You should never do it. Like, good heavens, we need to stop that language.
Yeah.
That's not okay for people to just, we have to work on your core, lying on your back is ridiculous. Getting up out of a chair is more pressure than this, that, or the other thing, just basic movements of activities of daily living generate more pressure than many things and what we do in the gym. And so we need to balance it, and we need to understand it, and we need to modify it, but we absolutely don't need to vilify certain things or certain movements or certain positions.
Especially in a society that generally doesn't move enough.
Yeah.
I think we should be taking down barriers, not adding barriers.
100%.
So yeah, that's very well put. And it also, is tied in with this pelvic floor concept, because if women are afraid of incontinence in the gym setting and whatnot, they're way less likely to wind up there in the first place, or go out and do activities with their children or family, or, go on vacations or hikes or things of that nature, right?
Yeah. The only way we want to continue to exercise is if it's enjoyable and positive. And if we're leaking urine, or we're worried about prolapse or organs falling down or falling out, like, that's not very motivational. No one really wants to continue to do that.
Yeah.
And we can change that. I think as a group, we can work together to facilitate positive outcomes for people.
Yep.
And to give them confidence. And I'm really big on teaching the people that I have opportunity to work with what's going on, what you've got, how it works, how you can change it. I don't own the solutions. You should own the solutions. I think of my job as helping you to build a toolbox to understand your pelvic health, and then filling it with a whole bunch of tools so that you can pick the right tool in the right moment for the situation that you find yourself in, so that you can do the stuff that you want to be able to do.
Mm-hmm.
I love that. Love that a lot, actually. I would love to, speaking of like exercise and modifications and whatnot, jump on to another topic known as the kegel. And I really enjoyed, I guess I haven't explained this yet, but I met Christine through school, where she came in and lectured our class on the pelvic floor and pregnancy. And I really loved your informative, I guess, rant on the kegel. Would you care to enlighten these kind folks?
Yes, I do have a bit of a rant. I'll share it with you because I think that we can do better. That's really my whole reason for the rant. I'm sure Dr. Kegel was a good guy, but Dr. Arnold Kegel in the 1940s was an obstetrician gynecologist who wrote a paper on the importance of the pelvic floor muscles for women. So this is brilliant because we had to get a start. We had to begin. So that was the first paper that had been written on the importance of the pelvic floor muscles. Problem is it was the first, and it's still something we're talking about now. It's 2024. We're 80 plus years later, and we're still talking about the kegel. So the kegel in the 1940s got narrowed down to squeeze the muscles around the vagina and do that many, many times, and thousands per day is better. And squeeze and hold. Didn't care whether we were holding our breath. It was only the vagina, and it was only ever about squeeze. And so it's not incorrect. It's just exceptionally incomplete. And we know so much more, and we need to move forward. And in 2024, we can all say out loud, pelvic floor muscles. We can do this. So we can talk about pelvic floor muscles and pelvic floor muscle exercise and pelvic floor muscle function. And we can really understand that even, again, where I was 20 years ago when I first learned about the pelvic floor, we were really just isolating the pelvic floor and trying to get it to work better. But we don't do that anymore. The pelvic floor has to work with the rest of the inner core muscle system. I think of it as, again, a group project, and the pelvic floor is the team leader. So we need to initiate pelvic floor activation and relaxation, but we know that it's not an isolated muscle group. The vagina has muscles that surround it. They are literally attached in the middle to the muscles of the anal sphincter, and they start right at the front of the pelvic floor. Right at the pubic bone at the front and go all the way back to the tailbone. I should have mentioned tailbone pain when I was talking about pelvic floor dysfunction. It's one of the big things. So yes, tailbone pain is another indication of pelvic floor dysfunction. If you haven't fallen and landed on your tailbone and you have tailbone pain, it is probably related to pelvic floor dysfunction. Anyhow, I digress. So we've got the vaginal muscles, we've got the anal sphincter, they're linked in the middle, and they both squeeze and they should unsqueeze. We have internal muscles, which is a big hammock-like sling-type system, starts at the pubic bone again, goes all the way back to the tailbone, and those muscles lift. And when we've finished with the task that required the lift, then we need to lower them down. So we've got front and back, we've got outside, we've got inside. We need to activate them, we need to relax them. They work with the rest of the core system. They should work automatically for us, but they don't always. If they aren't, we need to understand them, train them, sort out the details, give you the skills, put them back into the context, and then we need to learn how to use them so that we can actually take them and go jump on the trampoline. We can go to the gym and lift heavy things without leaking urine and feeling secure and balanced with the pressures. So squeeze your vagina or have a functionally integrated core muscle system that works really well with high-level activity and dynamic function, I'll pick the latter.
Yeah, Kegel seems like a very isolated, non-functional way to train, especially if you are in the gym or asking a lot more than just laying on your back or sitting and squeezing.
It's just so out of date.
Right.
It's just so old and incomplete and inadequate. And it ignores the really, really important lift mechanism and lower mechanism. And it's also typically been trained as the more you squeeze, the harder you squeeze, the better. And when I was talking about that stage and lighting crew, it's submaximal. These folks are paid by the hour. They're not on stage. Nobody's cheering them on, right? They are low level, very dynamic muscles, but they work submaximally. They just are there doing good things for us without needing to be super strong and powerful. So all of the focus on strength in your pelvic floor, we need dynamic pelvic floor muscle function, and we need it to integrate with the rest of our body.
Makes a lot of sense. You got anything to add there, Danny?
This Dr. Kegel sounds a lot like Mark Rivito, where Dr. Kegel got people sparked the conversation, whereas Mark Rivito, he's like an old school strength coach.
Okay.
Where he put a barbell on people's back. He got a lot of people into barbell training, but he's very dogmatic about his approach. And
there's only one way
there's only one way to do it, and like
any other way is the wrong way.
His practice is, I would say, fairly outdated now. So I thought those are two. There's a parallel there.
Yeah, I think it exists.
Yeah.
Like the first try is probably going to evolve, but we have to have a foundation to start from, right? Somebody's got to bring it up. Somebody's got to say, hey,
Exactly.
this is a thing.
Yeah.
But if we're stuck there 80 years later,
Exactly.
that's the issue.
Yeah, that makes perfect sense. I think anytime, at least for me, when I'm consuming any kind of physio or fitness related content online, whenever someone becomes or sounds very dogmatic about a given topic, that like instantly throws up
It's
like
a red
hazard
flag.
lights. Yeah, it's red flags.
Yeah, for sure.
Typically, because I don't know, humans, I think for the most part, are very complex. I think we pretend to know a lot of things that we can't truly know. It seems that a new explanation for back pain comes up every like 6 months or something like that. Especially with how rapidly information and misinformation spreads with social media. So I don't know. I think it also applies to the pelvic floor. Correct me if I'm wrong, but there are just many ways to approach these types of issues and whatnot, and no one way can fix all of them. Because you see like these Instagram reels and whatnot that are like, this one thing will fix your back pain. Maybe this one thing will stop you from leaking when you're jumping rope or something like that, right?
Yeah, it's a bit ridiculous. We are complex, interrelated humans, and I haven't really highlighted, but we'll take this opportunity relative to the complexity to say that, you know, we as physiotherapists try and really understand that every situation is a biopsychosocial situation. So we've got the biology, we've got the pelvic floor, what's it doing? We've got pressure in the pelvis, what's happening with that? But we also have the psychology of confidence or fear. And we have the social reality of the impact of leaking urine on the platform and what are the consequences of those things. And if we limit ourselves to just the pelvic floor, we're going to really miss most of the reasons likely why people are experiencing the things they're experiencing. So it's the pelvic floor in context that I try to promote. It's understanding that if someone's been through trauma in their life and they're holding tension in their body, then movement is probably going to be really difficult and it could be painful and it might not be all that successful. And so if I just fuss with them about their pelvic floor, and their tailbone pain won't get any better, but I don't understand why they have tension or why they're not moving well, why they have pain. Pain is a protective mechanism. People who don't have any pain are in big trouble in their life. So why is that pain present? It might have something to do with the musculature of the pelvis or the joints or the nerves in the pelvis, but it could also have to do a lot with other factors in their life. And I think we do our best work when we all consider that we are complete and complex humans and there are no quick fixes. Mm-hmm. There are some really logical, easy things that we can change and have good success, but it's going to be complicated.
Right. That makes, we've done a couple deep dives on pain and injury on the podcast and the complexities of it. I also think that's something that's not very, present with the general population in terms of like, just because there's pain doesn't mean there's damage in the body and things like that, because people will experience pain and instantly believe that there's something wrong with them, right? Which I think also relates to this pelvic floor thing where maybe you're experiencing some pain in that region or in the back and whatnot. And then you're immediately considering, I must have damaged something. There's something wrong with me.
Yeah. Many people that I work with who have persistent pelvic pain, whether that's related to really problematic menstrual cycles or pain with intercourse, pain in pregnancy, pain with movement, really believe that there's something damaged or they are causing damage when they are moving. And that's usually, that's a generalization, and I try to watch those kinds of comments, but it is commonly more complicated than that. And complicated doesn't always have to be difficult. It's just we have to consider that there are many factors with any one situation, and we do best when we are thoughtful about all of it and how it fits together.
Right. That makes a lot of sense. Anything you guys wanted to add on that?
There's nothing that aggravates me more when I see like a post and it's like, oh, this one biohack will change your life.
Yeah.
And it's just like, but the problem is that draws in so many people.
Mm-hmm. It's a good headline.
That you don't know what you don't know. And they just get sucked into it.
Yeah. Yeah. The number of times you see like, oh, if you have pain here, it's probably because of this one muscle. And it's like, what are the chances?
It's just a sure answer.
Yeah.
It would be nice though.
Yeah, it would be nice.
I mean, that would be handy if that were true. And so if you're not educated and you don't have effective, interested coaches, then you might just go down that path.
Our jobs would be a lot easier.
And I think maybe that's why people get drawn in, because they want an easy answer. They don't want the complex, hard path to fix something,
Mm-hmm.
So
it's that expert fallacy too, because I know there's people with doctorates or DPTs or MPTs or doctors of chiro that will say things and people will just automatically believe them because they have, these letters before or after their name. Yeah. And which it bothers me to no end when people prey on other people like that. It drives me insane.
Mm-hmm. Yeah, absolutely. It's not okay.
Yeah, it's very much not okay. Hopefully this podcast can be a little drop in that ocean to kind of change the narrative a little bit. If it even helps one person, I think this was worthwhile. Even
making waves.
Exactly, right?
That's the plan.
So that's kind of when we started our podcast too. Actually, we were like, if we can help just one person, it's maybe worthwhile just doing it, right?
If somebody listens to this and says, hey, I should ask about this, you've been highly effective.
Exactly. So
good.
We covered a lot on the pelvic floor and pelvic floor dysfunction. Is there anything else you wanted to add to that topic? Because I know we got about an hour-ish left. I would love to dive into pregnancy and whatnot.
I do want to just highlight one recent study that I came across when I was prepping for our conversation today, and that's a 2024 study that says women who exercise generally have greater pelvic floor muscle strength than women who do not exercise. So exercise is actually so important. And even if we're not exercising the pelvic floor specifically, we know as pelvic health physios that sometimes people need specific pelvic floor exercises and assessment and evaluation and a plan. But we also need to promote movement generally, which is what you guys are doing as well. And that's brilliant because movement creates movement and confidence, and it's great when we have studies that show this. We don't know that necessarily yet if higher intensity activity results in greater pelvic floor muscle strength, but we've also kind of just talked about the pelvic floor doesn't necessarily need to be endlessly stronger and stronger. It just needs to be present and enough. So anyhow, thought that would be kind of an important one. Super current research to throw out to support the work that you guys are doing. So thank you.
Very, very important. We have a saying that I stole from my physio, Adrian. We've had him on the podcast actually, and he says motion is lotion. And there's all these like cascading or snowball like effects from getting people moving, which is why we're such big advocates for it. And it's net beneficial in so many different ways that we could do multiple podcasts just listing the benefits, both physical and psychological.
100%.
Well, let's dive into pregnancy and the interrelatedness with physical activity. There is a lot of misinformation out there surrounding pregnancy and lifting and physical activity in general. A quick little story, actually. My fiance, she follows this lady on TikTok, and she was pregnant. She posted a video of her lifting. I'm not quite sure what movement she was doing, but if you dive into the comments, there's tons of people in there saying that you're a dumbass for doing this. You're going to lose your baby. This woman has previously lost a child, which is just sickening that this is happening to her. And of course, there's on the other end of things where people are pushing back against that narrative. But there's such a huge divide there, and it's still very prevalent in the world and in social media. So I would love for you to, shine some light on this topic. I mean, can women exercise while they're pregnant?
Absolutely. In fact, it is recommended. The Society of Obstetricians and Gynecologists of Canada recommends that all pregnant women exercise unless there are specific reasons not to. And there are some pregnancy-related reasons to not be exercising. Let's be clear. Unfortunately, people do experience complications which result in a reduction in their ability to be active in pregnancy, and that's tough. But outside of any contraindications to exercise from your medical professional, the recommendation is that all women exercise in pregnancy, including aerobic training, strength training, and flexibility training. Balance, of course, is also important and comes along with that. So following the same World Health Organization guidelines for exercise that we see, the only change is that we add in pelvic floor muscle training as a recommendation in pregnancy, specific recommendation, because there is some evidence to support that we can actually do some preventative work in pregnancy. Mm-hmm. But beyond that, the World Health Organization exercise guidelines remain unless there is a contraindication. And miscarriage is not. You do not have an increased risk of miscarriage if you are exercising, period.
I love that. Thank you for saying that.
That's big.
If I remember correctly, the CSEP guidelines, because I was looking earlier this week, they're about the damn same as just the regular adult activity guidelines.
Literally the same.
Yeah.
Except
the caveats that you mentioned.
Pelvic floor.
Yeah. So, and then, consult with your medical professional, your doctor as well for, any contraindications to that. If it's like a high-risk pregnancy or things of that nature.
Yeah, there's a PARMED X for pregnancy that if you are starting with someone new, then you should use that as a screening tool in exercise. And the individual should understand what their medical professionals are saying about their pregnancy. If there are risks or concerns, their medical professional will have told them about that. And if there are not, then we're good to go. There are lots of things that change, though, in pregnancy. Yeah. So it's not that movement is going to stay static. This is a different phase of life than non-pregnant, and so there are things to be considered for sure. But movement is always considered a positive unless there's something that your doc has said. We don't really see people being put on bed rest anymore, even because that used to be a thing, but it really isn't a thing anymore. Activity modifications, if you're athlete or if you have been told to be on pelvic rest or vaginal rest, that's a different conversation. You need to understand why, because there are usually some increased risks. They don't throw that around lightly, but if that's something that your athlete or you've been told, then there's a reason for it and you need to respect that. So we need to be thoughtful about what our care providers are telling us, but we can also ask questions about it. We don't have to just accept everything at face value, we can say, okay, well, what does that really mean? You don't want me to exercise. Does that mean I can't stretch anymore? Does that mean I can't do body weight movement anymore? Does that mean I'm not supposed to be walking? I have to walk for my job. I do have to climb the stairs. I need to get in and out of bed. So we can't not do those things. So movement can be modified, even in situations like that. What does that do? Well, if that person has goals of moving, then that honors that person's goals and it facilitates their ability to be active and to take advantage of the benefits to the best of their ability given their circumstance. We don't have to be black and white about things because we do know from other conversations already that, getting up out of a chair has pressure.
Yeah.
So we're going to do that. So what else can we do? But what are the guidelines and how do we keep people safe?
Like we've cracked the joke on here a couple of times. If you're having some sort of knee or back pain with squatting, for example, and you go to a doctor and sometimes you'll get the recommendation to just stop squatting. And, how you could counter with, well, I have to get on and off the toilet and it hurts then. So how do you want me to approach that one?
Am I just going to crawl in the bathroom? What do you want me to do?
Just get a bedpan? I don't know.
Yeah.
So it seems like quite similar.
Absolutely.
Yeah. I think maybe a nice way to kind of break this down for everyone is maybe go by trimester and see if anything changes for activity guidelines and whatnot. Maybe even starting at prepartum. So I've heard that it's a good idea if you're maybe expecting or looking to try having children or getting pregnant, then to increase your physical capacity kind of ahead of time. I mean, that's a good recommendation, I think, for many aspects in life. But is that correct in me saying that, Christine?
Absolutely. I think the stronger we are going in, the better our body is going to be able to adapt to the changes that are coming. And that's really the reality throughout, whether it's pre-pregnancy, during pregnancy, or in the postpartum period. We want to be able to respond to the challenges of whatever that stage or phase is going to bring. And if we have more resilience, if we have more capacity, if we have more dynamic function, then we're going to be able to be more dynamic in our responses. So makes a lot of sense.
Speaking of like capacity and functioning and increasing that, it seems very similar to other aspects of, I mean, whether or not you are or are not pregnant, increasing your capacity overall. It's just generally a good idea.
If you have a cushion, then your average day of challenge is pretty average, and you have this ability to have a tough day or a challenging day or to do more by choice. And to have the ability and the capacity to meet that challenge.
Right.
It's not different.
It makes a lot of sense.
Literally the same thing.
Yeah, it's the same, exactly.
Yeah.
I mean, pregnancy has its unique parts to it.
Yeah.
But the ability to manage those pieces is not different.
Right. I guess would that be cousin-in-law, I suppose? She's recently announced her pregnancy and whatnot, and she was talking about how she's so incredibly nauseous right now, so makes physical activity fairly difficult, right? So the modification at that time, maybe like for her, it looks something more like just walking right now, right? Versus doing something else, right? Because you kind of have to, I mean, again, this seems just so similar to just working with people every day, because I know none of us approach each client the same way. We have our principles, sure, or philosophies, but generally speaking, you individualize the activity to the client, and you don't just put out these cookie cutters for everyone and hope and just pray it works or something, right? So
I'm guessing that you would consider the person, the athlete in front of you, and their goals, and try and help them to meet their goals. You might challenge them to consider that there might be some goals that they hadn't thought about, but generally you're going to ask them, well, why are you here? What do you want? How can I help you? How can I support you? You're going to consider that on any given day. They might have something going on in the biopsychosocial realms that you might need to modify and adapt for, right? So when we look at pregnancy, there's going to be a ton of biological change, right? Over the course of a year, you're going to grow a human, deliver a human, and recover from that process. And so the amount of change that the body endures or goes through or is capable of, or however you want to think about it, is really, pretty darn remarkable. But then when you think about the psychology of that and the emotional realities of that, if that's not up and down for most people, put the hormones aside and just think about this change of life ahead of you. There are going to be some days where we're coping super well and we're pretty pumped and excited. And there are going to be some days where we're feeling worried and concerned, whether we're, know what we're doing, whether we can handle it, whether we've got the capacities and the support systems. Socially, what's that going to mean for work? What about my career? What about our relationship? What about the dynamic with crazy grandparents like I might be at some point, right? Like, how am I going to manage that mother-in-law of mine? Oh my goodness, right? Yeah. I could be that crazy mother-in-law. It's certainly possible. Try and tell the lovely ladies in my life that, like, you can just tell me to back off. I might not do it on my own, but I can be told. Yeah. Right? So the social impact and financial, right? If this was a planned pregnancy, if this is not a planned pregnancy, if you're having twins and you didn't ever contemplate that could be your situation in life, right? There's a lot of different pieces and variables, and everybody's going to adapt to those things in their own unique way, and that's amazing. But I think our job is to try and listen and understand and meet that person where they're at and find out what their goals are and help them to move forward. That
was very well put. Yeah. Let's maybe dive into the first trimester. So maybe, Christine, could you give us a quick synopsis on what's happening in the body? And I mean, do your best. I don't know if obviously anyone can Google this at this point in time. But what is it about activity that maybe we should consider modifying at this point in time?
So in the first trimester, the pregnant uterus is still fully within the pelvis. And so it's safe, it's protected, it's in there for a reason, it's small, but it's growing. So the baby is tiny, and then by the time we get into the second trimester and people are starting to show, or the baby pops up out of the uterus, there's a lot that's happened in there. So there's going to be increasing pressure on your bladder and on your rectum. We might start to see symptoms of pelvic girdle pain, which is the pubic symphysis and SI joint. And people are always super surprised when they're having like urinary frequency, going to the bathroom more often, or they're having some SI joint something. It seems so early, it seems so unusual. We always think of that as kind of a third trimester when I'm big and awkward and moving poorly, but there's a ton of pressure change within that first trimester, and so that's pretty significant. We've got hormones all over the place. The nausea, the vomiting, the fatigue, pretty profound fatigue for many, many women. And this is going to have an impact on exercise. And so again, we're going to need to figure out what is movement. What can movement do for me, and what can I do to stay moving through this time? It's a time when there's a lot of worry, there's a lot of anxiety, there's a lot of uncertainty, there's a lot of bombardment of social media and information, and so it's hard to filter through all of that emotionally as well. And so I think people do often become a bit apprehensive, and so to hear and be encouraged that movement is positive and helpful and important, that's pretty key, I think, but not to be necessarily to be pushed. We have to consider hydration and nutrition. Right. And rest. If we're fatigued, can we go into the gym and do the same kind of work that we do if we're coming in feeling refreshed? If I can't keep anything down because I've been vomiting pretty much all day for 2-3 months, should we be pushing? So there's some considerations. There's normal nausea and vomiting, and then there's this thing called hyperemesis gravidarum, and they're very different, and we need to respect that, because if you have someone who has hyperemesis, and this is I end up in the hospital with an IV, or like I literally can't keep anything down regardless of like layers of medications to try and help me to feel better. That's a medical situation. There's people who, like myself, brushing my teeth and I would gag a bit. Okay, that's different. Needing to have some crackers on the side, I need to eat regular small meals so that I'm not nauseated. That's very different. And so it's important, I think, to know that it's a spectrum from people who don't experience much at all to people who are, unfortunately being hospitalized because of the amount of nausea and vomiting. So respect, pretty darn important. Really, in terms of exercise, though, with those things considered, you can continue as previously. Okay. Enjoy.
Just individualize
it, and it's a time to start a conversation about the pelvic floor. Oh, okay, so and I guess oftentimes people are not disclosing pregnancy until they're 12 or 14 weeks along. But if people are looking a bit off and not like, is there anything we should be doing to modify? Like, or people may not want to tell you, they may not feel comfortable. The docs kind of say, well, don't say anything. I think that if the people you want to tell early that you're pregnant are the people that you want support from if you were to have a pregnancy loss.
Mm-hmm.
So it's not bad to tell people. It's just maybe not awesome to tell your whole workplace and then you experience a loss and everybody's asking you how the baby is and you have to go through that time and time and time again. But if you're key people, as coaches, I would see you as key people in people's lives. To me, it makes sense that you guys know so that you know how to support your athletes and also so that you could be there for them as an emotional support if they were to have gone through loss. So I think those are individual choices, though, but you may not hear about pregnancy until the second trimester.
Yeah.
You said something in class that really, really stuck with me, and I've very much carried it forward and spread it as much as I could. But you said that when you get the news, I think it was in class, if I remember correctly. But when someone comes up to you and tells you that they're pregnant, or you find out that they're pregnant, most people's common reaction is to get super excited about it, right? And as I understand that might not be the most appropriate reaction because you have no idea how this person may be feeling. And I think what you said was something along the lines of, instead of saying like, "Oh my God, that's so exciting," maybe something along the lines of like, "Oh, and how are you feeling?"
I'm a big fan of asking people how they're feeling about things versus me assuming that I know how they're feeling about things.
Yeah, because they might not have even wanted the pregnancy, right? It could be, right?
It absolutely, or it could have been super rocky already. It might be fraught with potential complications. If they've been having bleeding, it might not be exciting. It might be highly stressful, right? So how are you feeling about that? And then you can take your cues from there.
Yeah.
Yeah.
I know I'm planning on having kids eventually. I'm getting married this summer. So this has just been like a master class right now and getting ready for the pre-fatherhood. And then hopefully, we'll get into like almost like some advice post-fatherhood kind of thing, or post-pregnancy.
Well, to the best of my ability.
To the best of your abilities, yeah.
So one thing to do is to start conversations about the pelvic floor muscles. You have them, you want them functioning well. You might want to learn more about them. There are people who can help you learn about them. Yeah. Also considering contact and high-risk activities. So we don't want to be having impact. We don't want to be, falling off horses, and people who ride all the time, they don't need to, but I myself would not have gone out on a horseback riding thing because that would be terrifying at any time and certainly could fall. People who play certain sports or who do certain things often, that's not really the same conversation as, say, maybe somebody going out and playing recreational flag football or, volleyball. And, if you're a volleyball player, you're just going to hit the floor and you're going to do it well and it's going to be a smooth athletic movement. But if you don't know what you're doing on the volleyball court, you might want to back away, because if you can't coordinate things and you get hit in the belly, that would be really unfortunate. Yeah. So, I mean, not that it would cause, but could, right?
Yeah.
Would and could, a little bit different.
Yeah. Yes. Oh yeah, for sure.
Yeah. So it's almost kind of like we want to almost maintain the same like activity we were doing prior to the pregnancy versus adding in a whole bunch of new potentially terrifying variables.
Yeah. It's usually maintain or adapt to symptoms that are outside of our control to move as best as we can, but to respect the stage that we're in.
Yes, right.
Second trimester, usually feeling better. Yeah. Better energy. People who are going to be in that hyperemesis category may continue to experience nausea and vomiting persistently through the entire pregnancy, but for the rest, things are usually starting to settle, and that's a helpful thing. Again, pregnancy-related pelvic girdle pain or low back pain might start to be conversations. One of the things that people forget to do when they're pregnant, it's surprisingly common. I see it a ton, and people are like, "Wow, I can't believe how much better I feel with doing that," is stretching. As the center of gravity starts to shift, as baby starts to move up and out of the pelvis, we will see an increase in relative tension through the lower back, hips, hamstrings, and calf muscles. And if we don't keep that flexible, then we are likely to increase our chances of leg pain, sciatica, back pain, and SI joint concerns. So doing Reasonable stretching is often helpful and strangely forgotten, and pretty darn effective to modify some of those things. So worth considering. Posture starts to change, and we want to see the posture change. If your center of gravity is moving, you are going to have a different alignment of your body. So we should not encourage people to try and flatten their back and tuck their pelvis under. That's not helpful. It's really not helpful for SI joint pain and pubic symphysis pain. So allowing the back to have a natural curve is pretty important. We don't need to be clenching the glutes and holding the abdominal muscles tight to have good posture. We start conversations in the second trimester about diastasis rectus abdominis, which is a normal, natural thing. The abdominal wall is held together by connective tissue called the linea alba, and by 36 weeks pregnant, everyone will see a softening and widening of that. That is normal. It's natural. It's adaptation to allow for the enlarging uterus to have space. So the muscles will stretch, the connective tissue will soften and widen. That's happening in the pelvis. So the ligaments are softening so that we have increased pelvic mobility so that we can deliver these precious humans. And so the diastasis rectus abdominis has kind of been considered as something that we should be avoiding or preventing, and we actually can't prevent it. It's a normal part of pregnancy. What we want to do is we want to manage the pressures, and then we want to make sure we rehab it afterwards when we're done.
Makes sense.
Yeah, if this is a first pregnancy versus subsequent pregnancy, babies will be carried a little bit differently. Second, third, and further on from there, babies usually sit a bit lower. There's more pressure in the pelvis, even in the second trimester. And so also if you're in a second pregnancy or further, you have little people at home.
Right,
So
yeah.
generally people have full-time actual jobs. They are full-time busy growing a human, and they are full-time busy managing their household and parenting. And yes, hopefully throwing exercise and movement in there as well. So it's pretty full.
It's a lot.
Yeah, it's a lot. There's no doubt about it. It's exciting, but it's a lot. So if people are overwhelmed, yeah,
No kidding.
fair, valid.
I think that's another, point in the basket for trying to maintain your physical capacity in that trying to raise a child at home
Yep.
and be pregnant at the same time that sounds like a lot of work. That sounds very difficult.
Right? So, I mean, we're going to get to postpartum, but postpartum after pregnancy number 1, you're setting yourself up for pregnancy number 2. And if you don't get that capacity back, then second pregnancy is harder than it needs to be.
Right.
Having said that, getting that capacity back is not always straightforward.
Right.
So second trimester, we're modifying core training as required. We still need stability and we want to be balancing pressures, but we're starting to move away from like a just lie on your back supine core exercise, but the core is exercised with every single exercise, and core exercise is not bad. It's just how we do it and what we choose. So we might start to modify some of that, and also looking at higher impact, again, higher risk exercises and activities, and consider the goals and individualize. Again, some people feel great. I've worked with lots of pregnant women who continue to run throughout their pregnancy. They're just running less volume, and they're maybe doing some walk run by the end. And there are other people who are like, this is just not working for me right now. I'm going to change what I'm doing. Brilliant. Great. Is that okay with you, or would you prefer to be still running, and what can I do to support that? If you're okay with that, then that's awesome. What else are we going to do to make sure that you're getting everything you need?
Makes perfect sense. So at this point in time, if, say, for example, a powerlifter wanted to continue bench pressing, is there any contraindications toward that?
Nope.
Same old, same old. Okay, awesome. So if you're pregnant, you can continue to squat, bench press, and deadlift.
Yes, you might find that you need to change how you're doing those things. We might need to modify technique. We might need to change our approach. We might need to modify our goals. We probably won't be lifting as heavy. The belly does start to get in the way.
Right.
But it's not wrong to continue to do those movements. We just need to be super thoughtful and have guidance and expert advice from folks like you as to how to do that differently, because people don't know how to modify their own exercise. This is where the fitness professionals are so key, because you guys work with this, you see it, you understand it. So I'm having trouble with this. Well, you wouldn't just tell them to keep doing it, because they literally just told you they're having trouble with it. But might have brought that to you because they don't know how to modify it. They
Yeah.
don't know what
Right.
else to do. They don't
Yeah.
have a lot of diversity in their tickle trunk.
Yeah, that makes a lot of sense. So even something like the belly getting in the way, maybe even running into the thighs, giving someone the cue of let's try widening your stance out and let the knees drift outward a bit more instead of straight forward, can give you room to still continue squatting, right?
100%. Do something a little bit different. But you guys hold the tools for that. You're the ones that know what the different could be. Sometimes it's
Yeah.
just allowing them to explore different, but sometimes it's like, well, these are some of the possibilities for how we could change that up and still, keep going in a
Right.
forward
Makes sense.
direction.
I've even heard it was another podcast, a fitness one, talking to a pelvic floor PT, and she was saying something along the lines of even if someone's pulling or deadlifting in a sumo stance with their legs out really wide, and they get this feeling of, I don't know, like pressure or maybe incontinence, I guess pre-pregnancy or during pregnancy, you can get them to narrow their deadlifting stance up a little bit, and that'll put a bit less of a stretch on the pelvic floor. And I never would have thought of that, but I guess that makes sense when you have a muscle that's really lengthened with these additional demands on it. It's not going to be able to function necessarily as well as, a different time in their life, or, if, I guess, like pre-pregnancy is what I'm trying to say.
Yeah, and we might need to cue what's happening with the pelvic floor and that inner core system, because if it was automatically functioning and never had to have any conversations about it, but now we're starting to see some of those changes. Well, how can we help them to understand, pardon me, how that pressure balance works?
Yeah, that makes a lot of sense. Anything you guys want to add so far through? Nothing?
I'm just learning.
I think it's good to know, and it's good to
Yeah.
talk about. One of my training clients, actually, her and her husband are planning on trying for a baby in the next 6 months or so. And it's interesting, this conversation in particular, because we do quite a bit of deadlifting with her with a hex bar, a trap bar, and she's strong. Like, she reps, 200 pounds or so. And we were talking about her becoming pregnant, and kind of her initial reaction was, well, we won't be deadlifting when I'm pregnant, right? And I mean, I'm like, to be honest, I don't know 100% whether that's something we would continue to do or not. I'm sure it's very individual. But kind of like Thomas said, making those adjustments, or even say pulling from blocks where your bar is a little bit more elevated, or making those adjustments, or even for someone like her where, her goal isn't to deadlift, it's just to be healthy. So maybe we take that out and do something that she's more comfortable with, so that she doesn't even have to think about that stress, and she can train confidently, So it definitely gives you a lot of things to think about.
And if you can say, okay, but I've had a conversation and I know from somebody who does this regularly and looks into this that it's actually safe, maybe her goal would be, maybe she doesn't
Right.
want to lose that. Some
Yeah.
people I'll talk to who are contemplating pregnancy and they're actually trying to be proactive. And one of their concerns is that they will lose their fitness and the things that make them happy and bring them joy and allow them to feel balanced in terms of the mental and physical health piece. So I think what you guys promote is that whole person wellness. And so what are your goals? And if you're not sure, if it's a question that you don't know, then you develop a team and you build contacts and you send me an email and I'll get you the research study. If this is someone who loves research, then let's get them the data. If they just need, I looked into this, I had the conversation and it's safe. And then if that trust is there, then it downregulates the nervous system.
Yeah.
We can be calmer, we can proceed, we can enjoy, and we can do it without fear, which is so huge.
Yeah.
And so, you guys have the power to have those conversations and to facilitate that best scenario for your athletes and the people that you train and the conversations that you have.
Mm-hmm.
Makes a lot
Yeah,
of
I think in her case at least, there's probably a lot of fear just because of the unknowns, because it's not talked about, and you don't see a lot of pregnant women, at least I don't, being at the gym all day. A lot of them, it's cardio machines, and that's basically it. They're not really dipping into the weights, or they kind of cut out weightlifting from their routines entirely, which just kind of fuels that feeling or that thought that, oh, I shouldn't be doing this.
Yeah, I think we've really normalized that approach. While I'm pregnant, I must change what I'm doing.
Yeah,
I think we can
100%.
change that.
Yeah.
And you guys will be the mode of change, which is brilliant.
Awesome.
Danny, anything you want to jump in with?
I just think Amanda's going to be super happy that she can still bench press
Yeah.
during pregnancy.
That's his fiance.
That's my fiance. Yeah.
Excellent.
Yeah.
Yes.
She loves the bench press and she'll be glad.
That makes her happy.
Yeah, exactly.
But she's going to need to know how to balance pressure
Exactly.
Yeah.
Mhm.
because that's important. But
Yeah.
that's actually always important.
Yeah.
So it's, again, it's not different. It's just different.
Yeah.
Makes a lot of sense.
Yeah.
Third trimester. Should we jump in there?
Third trimester. So we're going to be moderating our exercise goals. We're not increasing at this point. We are maintaining, and we're maybe adjusting and adapting because fatigue, again, becomes much more significant. The body is definitely just harder to move around, just getting in and out of bed, rolling in bed. I have lots of conversations about the best ways to roll in bed. So if we're talking about those kinds of things, and these are fit, healthy people, it's just awkward, and you've never had a belly that sits in that place before. And so movement just feels very different. So for a lot of people, it's a time of kind of narrowing their movement focus, but still movement is beneficial. We're seeing an increase in the third trimester of gestational diabetes and gestational hypertension, and movement is a buffer to that. Low back pain and pelvic girdle pain, we know that if we've moved well, and we continue to move well, but moving well looks different in the third trimester. So, modifications, type of exercise, intensity, duration, maybe a functional focus, right? How does what I'm doing promote where I'm going? What am I looking at? We might need more treatment at that point as well if people are wanting to be more active. So sometimes we just need to work a little bit from a treatment perspective, whether that be a massage, chiro, or physio, just to support and help people to stay more in balance. We're definitely having conversations about the pelvic floor muscles. We're starting in my office anyhow to focus on labor and delivery preparation. There are things that women should know. There are things that couples should know about labor and delivery that have not been talked about, that could be talked about. The number one being, if you are in pain, you will have elevated tension in your pelvic floor muscles, abdomen, glutes. That's what happens, is we kind of lock down the region when we have pain. So the pain of a contraction is actually going to increase the pain in the tension, in the pelvic floor muscles. But in order to facilitate baby moving down through the stages and positions of labor into the birth canal and down through the pelvis to be delivered, we actually need length. We need to get out of the way. We need to allow the pelvic floor to lengthen and release and drop baby down into that pelvis, and not with each contraction resist, because muscles that are tense have an increased risk of injury. Muscles that can lengthen and relax in the presence of stretch, actually, we have a reduced risk of injury. So things to know, things to practice, things to be told, because breathing is obviously crucial, and it's highly connected with the pelvic floor. And I teach lots of diaphragmatic breathing, but it's got to connect with the abdomen. It's got to connect with the pelvic floor. So the more people know doesn't mean you're going to have zero risk of challenging delivery, but you feel more confident because you've prepared effectively and you've done everything you can. And that gives you a sense of confidence going into labor and delivery. So it reduces the fear. If we have less fear, we have less pain. If we have less pain, we have less tension. We get more endorphins rather than more adrenaline. We can start that positive cascade through education and information and knowledge, which just hasn't been, generally speaking, offered to women. I believe all women should be offered the opportunity to know more about their pelvis and their body prior to labor and delivery, and everybody should be offered postpartum rehabilitation following delivery, and we should be paying for this. There should be programs. Everybody should have access to this. It shouldn't just be people who have privilege.
Right.
Mm-hmm.
So it sounds like a very biopsychosocial approach to, this part of life.
Thank you for that.
Yeah. So, I mean, if you can kind of handle the people's concerns and whatnot, increase capacity or, maintain capacity through this trimester, it all seems to have this like back and forth effect with each other, especially if they find like maybe they're really worried about losing function as they become or as they progress through the stages of pregnancy. And then that reassurance can help calm that down, and then they can maintain something that maybe they really enjoy doing in the first place too, right?
Mm-hmm.
And I think helping people to modify fear at any stage, just having the conversation so you know what that person's concerns are. I meet people who are, pardon me, not worried at all about labor and delivery. Well, brilliant. I'll just give you the basic facts then, and we'll move on to other things. But people who are terrified, okay, we need to support that, and we need to validate that, and we need to acknowledge that, and not just oh, it's normal, it's natural, you'll be fine. That's not okay. That's dismissive. We don't want to dismiss concerns. We want to engage and validate and educate and support. And we can't fix everything, and we can't eliminate the fact that labor and delivery has challenges, but we can support people better.
Yeah. Well, very well put. Moving on maybe to the delivery to postpartum phase. I know my mom, I was an emergency C-section, and the advice she got was just take it easy for a few weeks. And that was the extent of her postpartum rehab, aside from maybe the 6-week follow-up with the physician. We could probably be doing better. Is that correct, Christine?
Thank you. Yes, we definitely could be doing better. So, C-section, you get more information than you do with a vaginal delivery about what you should do. But both delivery processes, pardon me, this is usually my cue that I'm talking too much. Both types of delivery deserve rehabilitation. So if we just back it up to basic kind of considerations, when we deliver humans, muscles are injured. Period. Yeah. We should just say this out loud. It's better.
It's a lot of trauma on the body.
Yes. And yet it's okay, because muscles that are injured, if they need to do a repair, will be repaired in the moment. So, if you think about a rotator cuff repair, that's late. That's months down the road. First, you have to get the injury assessed and diagnosed, and then you have to get a surgical consult, and then you have to get a surgical date. And then after they do surgery, what they do is they provide appropriate guidelines for rest and recovery, and then we rehabilitate people and we return them to normal activity gradually with a plan.
Right.
Sounds a whole lot like what's happening with labor and delivery. Muscles are injured. They're either stretched or they're torn or they're cut. They repair them right in the moment, which is awesome, actually. And they're exceptionally good at repairing, whether it be the perineum and or the abdomen. They're great. These are surgeons. They're super talented. It heals, and then we rehab, and then we return gradually to normal activity. It's kind of the same process. When we're rehabbing, we want to make sure that the injured muscles, the pelvic floor, the abdomen, or the muscles that have changed, which is that whole region through pregnancy, that they're functioning at a high level, and that we have a lovely base of support and a highly functioning inner core muscle system. And then we start to layer on the other muscles to get the functional movements and exercise and activity of daily living back. So when we're looking at a C-section delivery, we have different considerations, because not only was the abdominal wall, the skin and the abdominal wall open, but the uterus was cut. Right. So we have to be very respectful of the fact that uterus needs to heal well, and strain on the uterus is not a good thing when it's healing. We want that to be solid, because subsequent pregnancies and just life requires that. So the post-C-section guidelines are a little bit more firm, but again, it's a gradual progression of movement and activity based on how we're feeling and stages of tissue healing. We could do probably a whole podcast on stages of tissue healing, but I won't drag you through all of that pain right now. Basically, the body heals in certain ways, and with a vaginal delivery, by 2, 3, 4 weeks, a lot of that healing has occurred. So the 6-week point is a very arbitrary point. It's where they expect most of the healing to be done, and they can assess, and the uterus should be fully back to its regular size. And so it's become kind of a key point, but the rehabilitation process and the healing and recovery is really from day one on, and it is a gradually progressive process. If you think about a sprained ankle, you're on crutches for 3 to 5 days because you should be resting that, and it's too painful to be on it because the level of injury requires us to respect that and stay off of it. And so same thing with the first 3 to 5 days post C-section or vaginal delivery. We're going to have pain that is telling us to be respectful of the changes that have occurred. Then we start laying down the scar tissue in gradual layers. I think of it like saran wrap. So we're laying down scar and it's getting firmer and firmer and firmer. So the sutures are doing less and the scar is doing more. And then we reach a point where it's healed, but we don't have good function yet. And that's where we should be jumping in with an assessment and getting people a good evaluation of, okay, what's happened through the abdominal wall? What's going on with stability in your pelvis? What's happening with posture and alignment? How are your pelvic floor muscles? You need data. You need information. And you need somebody who can tell you, well, this is what's happening. And this is the phase of recovery that you're in. And then we need a plan.
Right.
Honestly, the same thing. If you had a partial tear of your hamstring, you would not go and worry about it day 1 or 2. And then, we would rehab and assess and rehab. And it's really the same. If you've partially torn your hamstring, you don't go running the next day.
Yeah.
If you've delivered a baby vaginally, please don't go running the next day. There's all these like posts on social media that are so unhelpful. And they create false expectations of normal and they set women back both emotionally and physically. And it's unhelpful. We have to heal and then we should rehab and then we gradually return back to normal activities. And if we follow those guidelines like we would for literally any other muscle joint injury, we do really very well. And so some people are more assertive and some people are more cautious in terms of guiding that. But those are the key basic principles of getting back at it. We need to consider and really be thoughtful about people's labor and delivery experiences. People do experience traumatic births, and that needs to be respected and understood. Postpartum depression, 70% of women will experience baby blues. That's not depression that needs to necessarily be treated, but 1 in 7 women will experience postpartum depression. That needs to be respected. We can't move in the same way. We can't take in information. We don't have time and energy. We're looking after a human. We're trying to figure out breastfeeding or bottle feeding. We're trying to figure out how we're going to get any kind of sleep and recovery. Nutrition is super challenging. Just having a glass of water here and there. So how do we exercise when we have the psychological, mental fatigue, challenge, trauma, like all of those things need to be really considered and addressed in addition to how are my muscles.
Yeah.
And some people are ready to get back on their feet early and some people need more time and support. And so listen to your person and hear where they are and make sure that they have the information and knowledge that they need and then support their goals moving forward.
That makes a lot of sense as well. I think even generally too, something that's not really addressed with injuries is like the psychological aspect of experiencing any kind of injury, let alone going through childbirth. But there's do you ever find that women will come to you and be very scared of moving their bodies postpartum? Do they feel like maybe like something has drastically changed with them that they can't do certain things anymore?
Yeah, I think again we're sort of led to believe that this might be a point of irreversible change. And it's a time where we might start to feel symptoms of urinary incontinence, or sometimes gas and stool control isn't as straightforward. And we can have pressure or heaviness or a feeling of prolapse or change. The abdomen is completely different. So it's pretty valid to say, like, I don't think I'm ever going to be able to do this. In that moment, it's really quite true, but it's just not a long-term limitation. This is yes, if you're 3 days post significant ankle sprain and it's purple and swollen and you're on crutches, you probably shouldn't be doing those things, but that's not a lifelong restriction. We can rehab this.
Yeah.
People do leak urine in the postpartum period because the pelvic floor muscles have been injured and cannot do everything that they should be doing. But that's not a, so when you're 95, you're still going to be leaking urine. That's yes, you have a muscle injury and the function of that muscle group isn't as good and we should rehab that and we should get you back to confident pressure balance in your pelvis so that you can feel like you can move forward and do whatever you want to do.
Right.
Mm-hmm.
I did want to ask, maybe I missed it, but during the third trimester, should we be avoiding supine or laying on your back exercises?
Generally, even into the second trimester and through the third trimester, we're moving away from that
Yeah.
style of core exercise. Yeah.
Or even like bench pressing. I've heard that the pressure from the womb on the abdominal aorta can cause some dizziness or even like, I guess, like changes in blood pressure.
Yeah. So it's called a postural hypotension syndrome.
Okay.
And when we're lying on our back, the pressure of the baby is more on the the major vein returning blood to our heart. And so if you have any symptoms in a supine lying position, you need to modify that 100%.
Right.
But we can be in and out of that position for function and movement and exercise. We need to, again, be adjusting and making sure that we're balancing pressure so that we're not seeing any bulging or doming through the abdominal wall. So breath holding, watching for that. And if you feel good lying on your back and you can balance the pressures effectively, then it's not bad. It's just something to be monitored.
Right.
But that's a great point.
Yeah, maybe even something along the lines of moving to like an incline bench press versus a full-on supine bench
Absolutely.
press. I did want to ask too, you mentioned breath holding. I'm assuming throughout all 3 trimesters, we're moving away from a Valsalva maneuver and then kind of moving toward maybe an inhale during the eccentric and an exhale during the concentric of a movement or something like that.
Yeah, it's just harder to balance pressure when you're pregnant because there's extra pressure.
Yeah.
So if we're avoiding Valsalva and bearing down and strain generally, I always sort of, my language is we have to balance the pressures.
Yeah.
And part of doing that is the breathing techniques that we're employing or choosing, right? Breath holding is a choice. Valsalva is and it's not a negative choice, just in that moment, and it might not be our best choice.
Right. Yeah. So again, it's kind of individualized as well, right? It seems like it all comes back to that. It's like a theme. I did want to ask too, kind of related to that, belt usage, maybe for a powerlifter that has become pregnant. Do we just remove the use of a belt from the first trimester onward? Or is that kind of the general consensus? Or
there's no research on belts in pregnancy or in the postpartum period.
That'd be difficult.
We have none of that. So we can't rely on that. But from a baby needs space and we shouldn't be smushing it. 100%.
That checks out.
Sorry,
I didn't want to take away from the postnatal conversation,
that's
but
great.
This question just kind of popped up and I was like, oh yeah, I should probably ask
those questions.
Yeah. Okay, perfect. And then in regards to that postnatal period, when could a client maybe come back to us? Because I'm assuming we're taking a bit of a break as, they go into labor and they're going to go through the childbirth process and now moving into the postpartum phase. When can maybe a client come back to us and start working with us as well?
So in my practice, what I recommend is that you get your feet underneath you, you get feeling like you have any energy and space to spare, because that's kind of important, right? Initially, baby gets all of the energy and you're just trying to, catch a nap where you can, which is quite challenging. Again, from my perspective, and I think other people who practice pelvic health might have some different perspectives, but until I am shown evidence that refutes the way I approach it, I'm going to stick with what I think is based in science and also common sense. So I'm a big fan of common sense.
Yep.
So we need to establish the inner core muscle system working effectively before we start to add extra challenge. So if people are feeling great by 3 weeks and they want to get assessed and they want to get that inner core going, then we can do that. So in my practice, it's less of a time frame and more of a capacity or readiness with that stability system doing a good job.
Yep.
So then we would encourage people to go back into general exercise and activity. If we take an average vaginal delivery, I'm usually able to be in there between 4 and 6 weeks. It takes somewhere between 4 and 6 weeks to make sure we've got that inner core muscle function going well. And so I usually think, okay, we need we need 9 months to grow a human. We need 6 weeks to make sure that we've healed effectively. And that's a bit of a sliding scale. So I sort of think about healing and early recovery and what is sometimes called the 4th trimester in some situations. So 3 months of that. And then from 3 to 6 months, we're returning into everything else that everybody wants to do.
Right.
And there are people who are ready by 8 weeks to get back to doing everything they were doing. And there are some people who need 5 to 6 months. And if your pelvis is being difficult or there are challenges, sometimes the really dynamic activity has to wait until after 6 months because we have to get that stability system to work really well before we start loading it. If we're not stable and we don't have the pressure balance, then adding load is just setting ourselves up for symptoms and problems. And I hate putting people on a postpartum roller coaster. I just want a gradual, smooth incline back to normal activity and recovery because I find it's a lot less frustrating for people.
It makes a lot of sense. It's kind of a principle I apply with just any injury because there's like this boom or bust cycle of pain and injury where
It's tough.
you try and do the thing you were doing before, it hurts, you stop, you lose capacity, you try and do it again, it hurts again, you stop, lose capacity, and rinse and repeat, right? So it sounds like, again, it applies here.
Well, and add frustration to that rinse and repeat cycle.
Yeah.
So then we've got the emotion and the psychology and the annoyance and what's happening from a muscle perspective with regards to protective tension. If the last 3 times you tried to get back into heavy whatever, it didn't go well, then...
Makes sense. Is there anything else you wanted to add on to the kind of postnatal section or any questions you guys had?
I have a question just in pregnancy in general.
Mm-hmm.
Why do you think there's such a stigma towards women lifting while pregnant? Like going back to the Instagram or story post, whatever it was, how like the comments were just abysmal.
Yeah.
Aside from like social media in general, just being a cesspool for like people and negativity and all that. Why is there a stigma?
I think it's come out of lack of information and a lack of knowledge. And I mean, I won't remember. I want to say the newest obstetrical and gynae association guidelines are maybe 2018. But historically, the medical community has not supported or endorsed movement in pregnancy, which I think has perpetuated some of that.
Yeah.
Worry, concern, fear. I mean, I think there's also a generational thing to it. If your mother says you shouldn't be doing that, then you're going to possibly listen to your mother. But if your mother is, a high-level CEO in a business that, sells many things in many places, but they actually don't have a medical background or a physio background, then that information, while well-intentioned and meant, I think, to try and help women stay safe and to it tends to be limiting, when people are told, well, you shouldn't lift that. And you're like, that's a 20-pound box and I can lift 200 pounds. Like, for sure, there's no reason why we can't lift and move. But I think that historically, women, upon becoming pregnant, were told to do nothing.
Yeah.
And so we've been pushing back against that, I think, for a long time. And lack of information or misinformation, I think, is even more now. But I think that when we look at historical levels of information around pregnancy, it's kind of crazy. I just think like our kids, our youngest is 25. So, in the same category as you guys. At that time, we were told to swaddle our babies and we were told to have them on their side and like literally propped on their side to sleep. Well, that right now is like absolutely ridiculous. Like no one would ever do that. We were told that we were to keep a chart to make sure that we put them equal time on both sides so that their head didn't get flat. This is 25 years ago, right? Like, so I'm old, but I'm not that old.
Yeah.
Like, it's kind of crazy when you think about some of the things that we were taught and told. And so science continues to evolve. One of the, the things I like to say about the Kegel is when you look at the internet, it's a holder of every piece of information that's ever been put on it, right?
Yeah.
The bad and the good. So you can get to the good stuff and the current and the accurate, but but you have to sort through like, I don't know what percent, I shouldn't even say, a lot of information that is out of date, incorrect, used to be our best knowledge, is no longer our best knowledge.
Yeah.
And I think pregnancy, because it's such a heightened state, everybody just kind of goes to the least common denominator
Yeah.
without validity.
Yeah.
There is I remember learning this bit of history in terms of like women's health and how it's been kind of horribly treated through like human history. But I remember learning that it was believed at one point in time that women had this, I guess you can call it essence, they called it, I think, life force, which sounds kind of absurd to me. But it was like you have this life-bearing force in you that if you perform activity, you reduce that life force that you have and your potential to bear children. Because I guess that was the only purpose for women back then, right? And I remember learning about that. I might have to fact check some of that, but I think that is correct. I'm not even sure how long ago that was, but I wouldn't be surprised if that was 100 years old, and which is fairly recent.
Wow.
Right. Yes, that's. I think it's a bit incorrect and
maybe a little.
Let's go with that.
yeah. So we've come a long way since life force.
Hallelujah.
Yeah. Okay. Another question I wanted to ask Christine was, I guess we kind of touched on it a few times now, but throughout kind of dealing with any kind of pelvic floor dysfunction or pregnancy, when should a person, again, consider maybe consulting with a pelvic floor physiotherapist to kind of wrap that all up for everyone?
So in my practice, I absolutely believe that knowledge is power. And unfortunately, to be able to teach somebody about the pelvic floor is still kind of held by pelvic health physios to a large degree. And so I think if you're athlete, if you need more information or you want to understand it better, you want to have a more complete understanding, then I think a referral to a physiotherapist is beneficial, because one session of, here, let me teach you how it is and actually show you the model and assess if you want me to assess, so that you feel confident, right? If you guys were wanting to teach me a new movement, you would teach me about it, you might demonstrate it, and then you would watch me and you would support me as I tried something new and different, and you would give me feedback on how I did with it. And then I would maybe need more help, or maybe I'd feel like, okay, great, I can go and implement that on my own, on my own time. So I feel like when we have those kinds of questions, then that's a benefit to having a consult or a conversation. If people have symptoms that aren't responding to the changes that you can make in the gym, then I think we need to talk about how and why that is happening and things that we could do differently. The pelvic floor, again, commonly hypertonic, overactive, tight and clenched, but sometimes not. And you don't really know. It's very hard to assess. It's not an area of the body where you have great internal feedback mechanisms. Proprioception is very tricky in the pelvis. And so if we don't feel confident that we're doing things correctly, the leftover conversations about the kegel, well, I have no idea if I'm doing it properly or not. If that's the case, then you're not going to feel confident. You're not going to feel empowered to move forward with a plan that you feel really good about. And so getting more information about that. I meet a lot of women now, it's exciting, who are coming just because they want to know more about their body and they want to understand and they want to be proactive, preparing for pregnancy, in early pregnancy. And that's really exciting. But of course, if there are any symptoms, any pain, any, the things that we mentioned that are in the zone of pelvic floor dysfunction, if it's not changing and it's still a concern, then let's have a conversation about it.
Yeah. I mean, even if I were to prescribe like a Kegel or something, Danny and I here, we have no clue how to even cue that. And if someone asks us, what's it supposed to feel like? We'd be like,
you tell me now.
You tell me.
Yeah, the language around that can be tricky, right? For men, for women, how do we facilitate helping people understand that this core muscle system works together and it moves. Your pelvic floor should be able to lift and it should be able to lower. And sometimes when you're lowering, it isn't lowered all the way. It can go further because we've been living in tension for, a wide variety of really valid reasons. Sitting in a chair, if you squeeze your anal sphincter, you will feel a lift. And if you unsqueeze, you will feel it lower. So I don't think we don't own that knowledge or those cues or that information. I just think we're super comfortable with it. So if you're comfortable with it, then you can have a conversation about how it goes, and then you can take that information forward as a person and implement it, knowing that you're on the right track. And if you have more questions, then you come on back. So I'm not a big fan of come and see me constantly, and it isn't about me at all. But if as a pelvic health provider, I can facilitate you understanding your body better, then I think that's a valuable thing.
Mm-hmm. I'm sure even just giving people the peace of mind to know that they're okay to go out and do things is huge too.
Mm-hmm.
Self-efficacy. Yeah.
And I can assess your pelvic floor while you're doing a squat, and I can talk to you about pressure balance if that's something that you're worried about, right? It's just a skill that a tool that I have in my toolbox as a care provider that I can offer to people, which can improve confidence, and confidence then allows you to go and do the things that you want to do without having to be worried. And without worry, we have so much more room for positive change.
Yeah, snowballs.
In a positive way.
Exactly.
The waves we were talking about.
Yeah. Mm-hmm. Did you have anything you wanted to add there, Daniel?
No. I'm learning. I'm trying to take it all in.
It's good. It's I don't know as much about this topic as you do. I knew a little bit. Now Danny knew very little kind of coming into this. So it's a lot to absorb.
Yeah.
Oh, it's a lot.
I'm sure I'm going to go back here and listen to this a couple of times to try and take it all in, because there's a lot here to dive into and to use, right?
Mm-hmm. And guess what? 5 years ago, my language and my conversation was different. So in 5 years, I expect we're going to know more.
Yeah.
Maybe we'll have to have you come back on and,
sure.
If we're still doing this
pelvic
thing.
floor update.
It'll evolve. Honestly, in the last 20 years, there's been an explosion of knowledge and information, and people who are excited about knowing this so that we can share it. It's no longer just a couple of us out there being crazy. It's actually now mainstream. It's normal, and there's a lot better access as well.
Yeah.
Which is really important.
Yeah. Danny, did you want to pull up maybe the Q&A?
See
if there's any questions that we kind of missed that some of the listeners put out. If
there's 5 questions on here. So the first one.
Hey, Danny, can you adjust your mic?
Sorry, my bad.
There you go.
I didn't hear myself in the headphones. So the first one we have from Florence Sheepers, who's one of my athletes as well. It's kind of it just says returning to heavy lifting after prolapse.
In the presence of prolapse is what I would sort of throw out, or after learning, after developing prolapse symptoms. Yeah. Probably that's been asked and answered, but I'm happy to highlight a few considerations. Sure. Prolapse is a downward shift of the pelvic organs or the vaginal walls into the vaginal space. Some movement with activity is actually normal.
Yeah.
But in the presence of symptoms, those are valid symptoms. The symptoms of prolapse and the objective assessment on our part of the amount of change in the anatomy those are not always strongly correlated. And basically, to get back into lifting heavy things, we need to have that capacity to balance pressure. We need to be able to make sure that the organs are staying where they are while we're doing the things that we're doing, or we can lift with the pelvic floor and support them in place and do heavy things. Sometimes, and this will be the first time I've thrown out this word, but sometimes a pessary, which is an internal support device, can be beneficial to assist with balancing pressure. It's basically like putting a brace on to lift heavy things abdominally, or putting a brace on your knee. If your ligamentous support for your knee is insufficient to do the task that you want to do, then we would rehab the muscles and we would work on movement patterns. And then if we still wanted to be able to do more, we might put on an external brace to support that knee while we did that activity. A pessary is like an internal brace to allow us to balance pressure more effectively, and sometimes it can be quite helpful. So that's a thing.
Nailed it.
No way. Yeah, a lot of these I feel like have already been answered during
Well, just you can skip those ones. You don't
Yeah.
have to. If you've been listening this whole time.
I have been. Relax. This one comes from. We'll do one of Gail.
Sure.
She
Yeah.
has a lot
yeah.
on here. How do I know if I have a weak pelvic floor, and how can I strengthen it if it's weak?
If you're experiencing symptoms,
Yeah.
then you might not have an optimally functioning pelvic floor, and you might want to get an assessment so that you can truly understand whether your pelvic floor is weak or whether it's overactive and not lengthening well, because if we don't lengthen a muscle, then it's very hard to tighten it. So a lot of symptoms result from people who have a tight, short, already turned on pelvic floor and cannot tighten it more to balance the pressures effectively. So from that already tight place, it feels like we're weak, but we're not actually weak. So we often need an assessment to understand exactly what my pelvic floor tendencies are, whether it is truly weak, whether it is tight and weak, or whether it's just over lengthened and it does in fact need strengthening. Pelvic floor muscle exercises, the updated Kegel, with a plan for strength and endurance training. So we have fast twitch muscle fibers in the pelvic floor and we have slow twitch muscle fibers in the pelvic floor. And so we need to train for strength at times and we need to train for endurance at times, but we need to have a specific local training plan that basically is going to fill in the gaps of what the muscles cannot do if in fact they are not strong or they don't have good endurance or they don't have good power, that strength, speed combination. So there are times where there are many times where we'll do specific pelvic floor muscle exercises, but they need to be, again, individualized and they need to be accurately completed. So that's one of the times where a pelvic floor evaluation can be pretty huge.
Sure.
Perfect. Any others in there, Danny?
There's one more. This one might be a tricky one to answer. How do I get over the embarrassment of peeing myself in front of, like, say, in the gym or in competition or whatever? Can you really?
I think maybe the idea is to potentially avoid it in the first place.
Or to take action to correct the variables that are resulting in it happening. So confidence is a great buffer to fear, worry, and concern. And we become more confident when we understand what's happening, why it's happening, and what we can do differently. So embarrassment goes away when you don't leak anymore.
Yeah.
If we're embarrassed because we're leaking and we're not changing it, then we're likely to continue to be embarrassed. But there are ways to move beyond leaking urine while we do things.
Sure.
Beautifully put.
That's good.
Awesome. Kind of just before we start to close out here, do you have any other advice for fitness and or rehab professionals or anything else you'd like to talk a bit more about here?
Just the last thing I'd like to sort of say is that I really believe that language matters and how we talk about things is really important. And we should keep opinions and personal beliefs and biases limited if we can. And if we are bringing forward personal beliefs and biases, of which I do have many, I try to identify that when I'm talking to somebody. I try and say, this is what I know for sure based on this research and evidence. And this is what I believe to be true, but we don't have evidence for. And this I know is a bias of mine, like the pelvis is the center of everything. That's a bias and I'm happy to state it, but I still talk about that. So language matters. Reassurance is really important. Validating people's experience, regardless of whether you understand it or not, is really important. And then not validating it and dismissing it, but validating it and facilitating change, whether that's within your sphere or whether that's just by saying, hey, you know what, this is not something I know a ton about, but I know there are people who are out there who are super motivated to help you. And I'm going to get you some names so that we can then feel, again, empowered to go on to the next step. It's hard to have conversations about this. So when people are dismissed or somebody looks super uncomfortable with that conversation, then it's hard to bring that forward. And that, obviously, I'm super comfortable talking about all things pelvic and not everyone will be, but it's just the fact of saying, like, hey, I don't really know about that, and I'm not super comfortable talking about it with you, but I know I can find someone who would be happy to have that conversation with you so that you don't have to suffer with that problem again. That's life-changing for somebody to bring it up and to be heard and to be offered support. There are days when people are just in tears in my office because I'm willing to listen and not judge and not ignore. And then anything is possible from there. If we don't have those conversations with each other, I think we really just limit the potential for that person's growth and personhood, and it doesn't honor who they are.
Validate the experience is super important and don't dismiss it. I think everyone can probably think of a time in their life when they brought a concern forward about anything and was dismissed and felt really invalidated, and how, especially if there's a moment in time where you're trying to be vulnerable with someone and that doesn't come easy to most people. That's why they have a whole separate word for it called vulnerability. And to have that dismissed like that is very psychologically scarring.
And it happens all the time in the pelvis because it is hard and people aren't comfortable, and we all have our personal experiences and challenges. And when I started doing this, I wasn't super comfortable either. But just be present.
It's a very, very good piece of advice.
Awesome.
Anything else you folks wanted to add there, Kelsey, Danny? Okay, well, I think we'll start closing it out here. Thank you very much, Kelsey and Christine, for both coming on the podcast today. The conversation you guys had earlier about pelvic floor dysfunction, I was just sitting here in awe, and I was like, I can't believe this is happening on the podcast. I think a lot of people will get a lot of benefit from that moment during this episode, and I'm very excited to share it with everyone. Thank you so much for both of you guys for putting aside some time for us and coming to hang out in my little basement here and talk about all things pelvic floor and pregnancy. I guess maybe just to start, Kelsey, where can everyone find you if they want to find you online? Maybe they're looking for a coach or a personal trainer. Where can they find you?
Yeah, so online, I'm basically only on Instagram at this point, but first name dot last name, Kelsey.Goodmanson. If you want to find me in person, I'm either at Rise Strength or at Good Life in Preston Crossing in Saskatoon.
Perfect. Okay, thank you. And Christine, do you have any, where can people find you? And do you have any resources that you'd like to share with people?
First, I just like to express my thanks to Kelsey for being vulnerable and having the courage to have the conversation today. It's not easy. It's not easy to do it one-on-one in my office for people, and it's certainly not easy to do it in this kind of a venue, but it is life-changing for a lot of other people to have that. And to the two of you, gentlemen, for being willing to talk about the pelvic floor and to take a reasonably old person who doesn't power lift but likes to be fit and move her body and allow me a venue to hop up on my soapbox and talk about all things pelvic. I really appreciate that. I think that you guys will change the conversation. I don't think it's going to happen from a physio perspective. I think it's going to happen from a person by person conversation and fitness professionals. You guys have so much access and so much power out there. So thank you very much. I do not have my business on social media because when I'm done my day, I actually want to be done my day, and I don't want to manage social media after that. So, and I'm not ancient, but I'm an older person who doesn't really love a lot of social media. So there are great pelvic health physios who are doing wonderful things on social media. Find somebody who has some experience and talks about things in a balanced, reasonable, person-centered way and follow them up, because there's lots of really good stuff out there. My business is called Women's Wellness Physiotherapy because pelvic health as a niche is a little world in the world of physio, and I have further narrowed that to focus on women's health primarily. So my email is christine@www.physiotherapy.ca. 2 W's, not 3. That'll always bounce back. It's not the World Wide Web. It's just women's wellness. And happy to have questions by email. And I have a website. It doesn't have piles on it because I'm not much for marketing. I just like to try and help and support women.
Oh, we very much appreciate that.
Yeah. Thank you, Christine.
Yeah, I'm sure probably the three of us will have to send you an email at some point in time because things are going to come up. And
Yeah.
I think we have that, I know Danny and I have that relationship with our physio, Adrian, where we're not sure about something and we'll just send him an email or a text or whatever. And just to bounce like something off him, like, hey, what can I try? Or should they come see you? And like sometimes getting someone to see a physio at the first instance of something kind of being wonky is a large financial burden. So we try and like, I think stay within our scope, but try and figure out find where that ends and where the other scope begins.
Yeah.
I think it's super important.
If there's anything on our end we can adjust or fix before we send them off, I like to do that first.
Well, and movement, nobody owns movement.
Yeah, exactly. Yeah.
The movement is in everyone's scope if they choose to put it in their scope.
Yeah.
And this is about movement. So yeah, we're available. And to be clear, it doesn't need to be me, right? I have many highly talented colleagues. There are so many people doing great things out there, and looking at it from different angles and perspectives. So track down somebody that fits, that vibes with you, and that is willing to support where you're at and what you need.
Perfect. Well, I think with that, we'll
Great.
close it out there. Thanks so much again, Christine and Kelsey.
Yeah.
Thank you, guys.
And thank you to all the listeners that have made it this far in the episode. If you find someone out there that is dealing with any issues that we talked about today, send them this episode, share it on Instagram. I think the more we talk about these things, the better. The more we normalize talking about these things, the better it will get, and we can help shift those tides and make those waves. So I think with that there, we'll leave it. Thanks again for listening to the Aches, Pains, and Gains podcast. Peace.